And for clinicians, I don't know how relevant it is because you're not going to be able to send these sort of genetic markers, but definitely interesting for research purposes and maybe going forward to phenotype those patients. So,
okay.
Can we just go back to the immunogenicity issue? It actually started for me with Michael's paper about azathioprine use in pegloticase.
Oh, somebody read that paper.
Yeah, yeah, and I waved it around for a few weeks, and people told me stop it. But you know, I did that in my patients as well, and it worked very, very well. Michael, how do you see the evolution of this concept, that it's gone from azathioprine, then a number of case reports or case series with methotrexate, and now we have a controlled trial, the recipe trial looking at mycophenolate?
Yeah. So, well, first of all, a shout out, if I might, to John Botson, because he sort of single-handedly pushed methotrexate early. When we started with azathioprine, we were a little nervous about methotrexate, and actually Pooja Khanna presented the recipe study today and made the same comment, because we figured a lot of our gout patients probably drink alcohol, so we were trying to avoid it. But it's a logical drug. It's a drug we know how to use, and ditto Cellcept, ditto mycophenolate. So I think the more the better. Basically, it looks like there's also an abstract about the Mirror study, which is the methotrexate study, and another abstract actually about azathioprine. So it's kind of a full house, and right now I think we're waiting for the full information to come in, but it's looking like this is an approach we can use. These are drugs we know, and being able to pick and choose among them is probably the way to go, because we want to, consider our patients individually. So I think we're getting somewhere.
true. And again, the study that I highlighted, 20% of us are already doing this. So this is a claims data with pegloticase, and 20% of patients are on some sort of immunomodulation. So people are already doing it. But I don't know, I always worry about azathioprine given in gout patients, because while switching or doing something, if they start taking the allopurinol or azathioprine together, that does get into problems. So I always worry, even though we never started together, but for whatever reason, when stepping up or stepping down, that's a potential issue that can happen clinically.
Yeah, I think that's right, Bella. One has to be pretty careful, of course. I mean, it's with Krystexxa, so you shouldn't be giving allopurinol anyway, but it is a concern. And Jack, when I submitted that paper, one of the reviewers kicked back and told me about a little-known paper from the 1970s that allopurinol actually has urate lowering properties, but not enough to account for benefit. But they said, how do you know the benefit of allopurinol isn't because it lowers urate? Probably not.
So let's go to we got a few minutes, that this issue of cardiovascular effects with febuxostat, that trial is coming up. That's going to be presented, I think, coming up. That's called was it PROBE study?
FAST trial.
Yeah. FAST. So what's seen there, and it's going to change our thinking about febuxostat, which seems to have a pendulum about cardiovascular risks. It does, it doesn't, it does, it doesn't, and now this study says it doesn't. Michael, what's your take on this?
I could write a book on this. So let me start by saying that the FDA did what they had to do. There was a signal in the original phase 3 studies. It wasn't significant, and they asked for a phase 4 study, and that's what the CARE study is. And that had a signal and a secondary outcome that is a serious outcome. And so they had to black box this thing. But the CARES trial, however well-intentioned it was, had enormous problems. Bob Turkeltaub was talking about this today. Half the patients didn't finish the trial. Most of the MIs were after people were off the drug, and there was no control. So even if it showed what it showed, it didn't show that febuxostat raised risk. It just showed that it wasn't as low a risk as allopurinol. So we have a few studies that run against it. There's a large study out of Choi's group that's retrospective with 100,000 Medicare patients that showed none of this effect. There was a contested study from Europe called the FREED trial that showed none of it. And now this study from Europe called the FAST trial, which looks like it's going to show none of it too. So how we're going to, how the FDA responds and how we respond is probably different. I think actually the most important thing out of the CARES trial was that patients who didn't take aspirin were the ones who got into trouble. If you had cardiac risk and you took aspirin, you didn't have this problem. So you should probably take your aspirin.
Very good. All right, folks, want to thank you for joining us. We're going to ask Bella and Michael to sign off, and we're going to bring in our next two guests on The Tonight Show.
Thank you for having us.
Guys.
Thank you. Bye-bye.
Hello.
Hi, everybody.
So we're joined now by our RA faculty for our mid-meeting recap. We're joined by John Kay from Massachusetts and Catherine Dow from Texas. Hi, folks.
Hello.
Hey, Jack. Hi, Artie.
So the perfunctory beginning of, what do you think of the meeting so far, John?
Well, it's very different. I have not left my house. I've not left my office other than for dinner. I've not put the 10,000 steps on every day, but you can get from session to session very easily. The other nice thing is that you can see a session after it's occurred. At the annual meeting when it's live, if you miss a session, tough luck. But here you can go in and look at it at your convenience again and again. There was a session today, Gerd Burmester talked about the history of biologics, and he had a slide about serendipity. And I missed the serendipity of walking through the exhibit hall, and not just meeting friends and other people whom I've not had the privilege of meeting before, but also passing by a poster that I didn't expect to look at and learning something and piquing my interest. So the fact that you're limited to seeing those things that you seek out limits the educational experience somewhat.
Catherine, what did you tweet today about serendipity?
Oh, that basically when you're trying something for one thing and it ends up you're finding out something else. It's kind of like you stumbling onto me.
Well, that's because you're petite, and I stumbled over you actually on rounds one day.
That is true. No, but I agree with John. I mean, I actually like the virtual format, but next time I'm gonna get a hotel room and expense it to you, because like my kids keep busting in. They're like, "What's for lunch? What's for dinner?" And I'm just like, "Leave me alone. Leave me alone. I'm in the middle of videoing."
Artie, how are you handling that with your boys?
It's tough. I mean, it's everybody's doing much more stuff at home, and I guess the question I put to the panelists is, EULAR announced they're going to be hybrid. So, would you all, all things being equal, now would you say, you know what, this virtual is pretty good, or no, I miss going poster to poster and just meeting old friends and stuff. What are you going to do?
I'm old-fashioned. I'd like to attend in person because I do like to give hugs. I like to, get the freebies. And I just, not only that, get this, I'm actually got vaccinated, or I'm in the vaccine trial now for COVID-19. Yeah. And so hopefully I did get the real thing. I mean, the first injection went well. I haven't grown an extra head yet, but I think so far so good. I'll get my second injection in a few weeks.
We'll be looking for that.
Jonathan, were you going to go to EULAR, or are you going to this virtual thing hook you?
Well, surprisingly, I haven't been on an airplane since March 7th, and I've forgotten what it's like to get frequent flyer miles. It all depends on how safe or unsafe it is. But aside from that, the Europeans probably won't let us in. It'll depend on public health. Will travel bans still be in place? My institution won't let us travel. If we travel outside of the country or even to an unsafe state or have to take an airplane flight, we have to quarantine for 14 days on our own time.
Yeah. Let's get into RA. And you guys have been covering RA. There's been a lot happening at this meeting so far. Let's start with something that's really impressed you. Catherine?
Well, I think it started out with the great debate. We have Vibeke Strand and then we have Michael Weinblatt. I mean, it was a beautiful discussion, and the audience actually, so discussion was basically after methotrexate failure in a patient with rheumatoid arthritis, what do you do next? Would you go straight for a JAK inhibitor or would you go for a TNF inhibitor, right? And so they each presented their case, you know. Vibeke Strand was like, well, it's oral, you know, it's quick on, quick off. It has great efficacy. I mean, just as good of an efficacy as TNF inhibitors. And yeah, it can cause shingles. Yeah, it can cause VTEs and MACE if you use a higher dose. And then here comes Weinblatt coming in. He's like, one word, 22 years of experience. And so, you know, and I don't know whether that is trying to scare us because we're afraid of the new and we want to stick with the old, you know. But he has a point, you know, it's something that we're familiar with. Yes, insurance is going to cover a TNF inhibitor before they're going to cover like a small molecule in certain states. You can use it in pregnancy. There's multiple indications, anything from rheumatoid arthritis to uveitis, SPA to hidradenitis, and now immune adverse events from checkpoint inhibitor therapy. So, I mean, yes, there's a lot of use. So that begs the question, like, what would you do? And that's something that I kept in mind throughout the last few days that I've been at ACR, because I'm coming across these really good posters, you know, posters about like, you know, there's a meta-analysis on head-to-head JAK inhibitors that they're looking at systematic reviews from UT Southwestern, and they're talking about how, you know, they're comparing UPA, Berry, Tofa, and filgotinib to like the TNF inhibitors, and they found that perhaps UPA and okay, Jack, you got your hand raised. Tell me.
You're way over 45 seconds.
All right, I'm sorry. I'm so excited about this. This is awesome.
Well, I control but I want to tell you one thing. Michael at Room Now Live that Artie and I run was asked on a panel that is with John O'Shea and other RA experts, what drug are you going to give your mother or your sister? Methotrexate, a TNF inhibitor, a JAK inhibitor. Everybody in the panel said a JAK inhibitor. And they weren't necessarily, I can't reason why they would be forced to say that. But so I found it interesting that Michael's arguing the other point, which really feeds into the rheumatologists who always want to use TNF inhibitors. But let's move on. John, what did you like that so far at the meeting?
Well, there have been a whole bunch of interesting things. I think that it's the year of the lung. You've got a couple of abstracts about rheumatoid arthritis, interstitial lung disease. Jeff Sparks presented an abstract that showed that ILD was more prevalent among older patients with rheumatoid arthritis. He also presented a oral presentation where anti-citrulline filaggrin antibodies seem to be a biomarker for the development of interstitial lung disease. A talk that I'm looking forward to tomorrow at the plenary session looks at citrulline reactive B cells in the lungs of patients with early rheumatoid arthritis and at risk rheumatoid arthritis. So the lung is sort of the alpha and the omega. It's the organ in which rheumatoid arthritis might start, and it's the end result of established rheumatoid arthritis. So the lung is really becoming a rather prominent topic at this meeting.
You know, Jeff, he did last year at ACR his own brass review showing a lot of lung stuff in ILD. And this was a claims-based review where he showed all that stuff where lung is seen, it was 5% of the population claims data, but it was associated with death, you know, and infectious death, cancer death, but most of all respiratory deaths. So it's a really bad player.
Absolutely.
The abstract today by Jeff, and I think both of you may have hopefully saw that, the RA seam, the tapering etanercept, and that generated a lot of interest. Some of it about what background Jeff was using, what Castle was the formation of the background for his Zoom call. But what did y'all get to see that? What did you think? It's tapering methotrexate versus tapering etanercept in people on combination. That was, I think, really a very definitive study on tapering, which is a very important topic.
Absolutely. I did a video for RheumNow today, so I'll give a plug for that if people want a more in-depth discussion of that abstract. Tapering is a theme at this meeting. on Monday, there's the Norwegian study, which looked at stable versus tapered TNF inhibitors in patients with rheumatoid arthritis who are in remission. Jeff's study sort of follows on the PRESERVE trial and the PRIZE trial, which looked at tapering versus discontinuing either etanercept or methotrexate. Jeff's study was different from those. Those studies looked at patients with low disease activity or remission rheumatoid arthritis. Jeff's study looked at patients who were in SDI remission, stable SDI remission. The definition of the activity was patients with very well controlled rheumatoid arthritis. There wasn't a strict definition of control at the time of entry, but he showed very nicely that getting rid of the methotrexate was the better way to go, that if you stop methotrexate, the etanercept continuation as monotherapy seemed to control remission or continuation of both, but much better than if you stop the more expensive etanercept. So the bias is always to try to stop the more expensive drug, but here the better outcome comes when you stop the methotrexate.
Well, if you look at patients too, I mean, what would they prefer? Most of my patients prefer to stay on etanercept and stop their methotrexate because, you know, it's convenient, it has less side effects. They're not losing their hair. They're not having like some of the oral side effects, nausea, vomiting, and having to have their blood monitored every 3 to 4 months.
Well, my patients like it because they can drink alcohol.
Oh, my patients don't drink. They're good.
Yeah. Well, they're Texans.
So it's about a couple of minutes left. I know you all have your schedules planned out thoroughly. What are you very excited about seeing in the remaining couple of days of the meeting?
Well, there's more to see than there's time to see it. Certainly the ACR rheumatoid arthritis management guidelines, which are going to be presented on Monday, are going to be very interesting. It's not necessarily going to be novel, but it's going to be a synthesis of past knowledge. There's a session on Monday about predictors of rheumatoid arthritis responses, where there's a Mayo Clinic study that used machine learning to look at pharmacogenomics to come up with an algorithm for methotrexate response. This is a theme where machine learning is being used to do a lot of things. There was a great abstract on Friday looking at machine learning to read hand x-rays and look at joint space narrowing. Really very elegant study out of Taiwan that might actually give us the sharp scores that radiologists are reluctant to do because of the lack of time. There's another abstract on Monday using machine learning to determine a rule to predict response to sarilumab. Ernest Choi, Peter Taylor's looking at whole blood transcriptional changes following filgotinib administration. And then, as I mentioned before, there's that tapering study out of Norway that's going to be presented. So there's lots of good stuff. And on Sunday, the plenary abstract about citrulline reactive B cells in the lung. And then an interesting session at 3 p.m. where Ron Van Vollenhoven, Peter Taylor, and Mike Hollers are going to talk about resetting immune tolerance to prevent rheumatoid arthritis. So really, we've come a long way since the first ACR meeting that I attended in 1986, where we didn't have biologics, and we certainly weren't talking about remission, and we weren't talking about prevention. So it's a very exciting world that we're entering.
Catherine, what are you looking forward to?
Well, tomorrow, I mean, early in the morning, they have the Thieves Market poster. And, you know, I'm like a sucker for good titles. They have titles like Disease of the Soul, Think Beyond the Obvious, and Practice What You Preach. I mean, come on, that's such a grabber. And then afterwards, I want to attend this lupus lecture, actually. It's the state-of-the-art lecture, The Future Is Now, presented by Dr. Mary Crow. They also have a conflict around that same time about the EULAR treatment recommendations for RA, psoriatic arthritis, and whether or not you should follow algorithms in your clinical practice. And then on Monday, I'm going to definitely attend the guidelines for RA, JIA, and also the FDA update on safety.
You know, there's a lot of stuff that is going to be presented. Is there anything that you wish was going to be presented that's not on the program? 10-second answer for either of you?
Is John still there? Did he?
I'm still here. You left me speechless.
Okay.
There's so much on, well, there's not a lot on biosimilars this year. So, but I'm not sure how much more there would be to present about biosimilars, given the reluctance of the United States to allow us to use them.
It's going down every year. Artie and I have just been tracking it. It's
19 this year, down from about 25 last year, abstracts.
Yeah.
All right, folks, we want to thank John Kay and Catherine Dow for joining us. They're going to sign off, and we're going to bring in our next two panelists who are representing psoriatic arthritis. There's Eric and there's Robert. Okay, let me begin. Welcome. We're going to talk psoriatic arthritis in our mid-meeting recap. Joining us is Eric Ritterman from Illinois and Robert Chow from Virginia. Welcome, gentlemen. Robert, you're on mute. You want to unmute yourself? That's going to be good. All right.
That's a good idea.
It's always the best way to begin. All right. Let's quickly ask you, tell me one thing you like, one thing you hate from the meeting so far, this virtual meeting. Make them quick answers. Robert.
One thing I like is I can neither confirm or deny that I'm wearing my pajamas still, pajama pants. And the one thing I hate is I don't get to see my colleagues in person.
All right. Eric.
Yeah, I like the fact that the ACR was nice enough to bring this meeting to my basement for me so I could watch. I actually think that the setup has worked really well. I've been very impressed with the structure of the program and how they put it all together and how you can access everything. That's been pretty easy. I miss seeing people. That's the hard part. I've missed seeing people for 7 months now, and that's the hard part.
Get a dog. That's all we can say.
I got to, and they bark in the middle of the meeting.
A ton of PSA abstracts, I mean, compared to years past. We're midway through the meeting. Rob, what's stuff that you've seen so far that you thought was great at psoriatic arthritis specific wise?
Right. Yeah, so definitely a lot of abstracts on, new therapies and continuation extended study, 52-week extension studies on drugs like, secukinumab as far as sustained improvements in psoriatic arthritis with axial manifestations, guselkumab, a 52-week study, again, sustained response in all major disease domains, improvement in enthesitis and dactylitis. You had rifilgotinib, post hoc analysis with improvement in dactylitis, and also the 52-week extension with improvement on enthesitis. So definitely a lot of new therapies and probably even more coming up.
All right, Eric, what's happened so far? 2 days in, what's the top thing that someone who hasn't been paying so close attention to psoriatic arthritis should go back and look at?
Well, I think the two top things. I mean, in contrast to some of the other meetings the last few years, there hasn't been a ton of sort of new molecules, new stuff. The one exception here are the two upadacitinib presentations, and those data were presented at EULAR. This is the first time they're showing up at ACR. They're both oral abstract presentations, and really good trials on upadacitinib in DMARD failures, and then upadacitinib in biologic DMARD failures, and they set the stage for a kind of a shift in our management of psoriatic arthritis more towards JAK inhibitors in the future.
Have either of you seen anything so far that you're going to take home and change your practice over? Incorporate right away?
Yeah, I mean, I definitely will. I posted a video about this actually, about just adding more tools to our arsenal. That's what I like to say about, especially tailoring treatment to, let's say, an enthesitis predominant patient or dactylitis predominant or skin predominant. But I think one of the big themes this year is definitely enthesitis. We had there was a great lecture by Dr. McGonigal on enthesitis recently. A lot of studies, we just mentioned a few on enthesitis, focusing on enthesitis. There's actually one pretty interesting study that they broke down treatment groups into no treatment / NSAIDs, conventional DMARDs and biologic DMARDs. And they actually found that I think more than 80% of patients had resolution of enthesitis despite the treatment group, which was rather interesting, because that sort of throws up the question, do you even need to treat enthesitis or tailor treatment for enthesitis?
Eric, what about you?
I haven't seen anything I'm going to take home yet, but what Robert brought up is sort of interesting. One of the sort of new studies here is this Achilles study, on Achilles tendonitis with treating Achilles tendonitis with secukinumab. It's kind of a mix of psoriatic and spa patients who had primarily Achilles tendonitis. And they didn't achieve the kind of resolution that they had hoped for. So they missed their primary endpoint. A lot of other outcomes were better. And I think that the abstract, Robert alluded to, is sort of interesting because, these people sort of come and go. One of the more challenging pieces of that abstract was that you got into the study by having Achilles tendonitis clinically and on MRI. And yet when the MRIs were read centrally, a little over half of the patients actually had Achilles tendonitis when read by a radiologist centrally. So it brings into the question sort of what is enthesitis? Is it clinical? Is it imaging? And how do you sort of sort between that? And how do you? I mean, this is the thing we've struggled with for a while in psoriatic arthritis. Is like how much do you need to treat in those patients?
So Eric, one of the things, it's not solved at this meeting, but there's a lot of data that addresses that. And just between us and the wall and the 135 people online, is axial disease in PSA the same or different than axial SpA?
I don't think we know yet. I mean, I think we keep asking that question. The problem is that there isn't, there's only one study that really looked at it, and that's this Maximize trial, which there's some data here with the MRIs, and it's a study of secukinumab in psoriatic arthritis patients with axial disease. Everything else we've seen is kind of a sub-analysis of a PSA trial. And again, they said, well, you have axial disease because the investigator at the site said you had axial disease. And yet when they read those images centrally, a lot of them didn't have the changes they said they had. So we don't know what it really means. One of the extracts that I saw that this week that is kind of interesting, it was an abstract that came out of I think it was the Psoriatic Research Consortium, where they looked at a group of patients, some with just basic psoriatic arthritis without axial involvement, some with axial involvement, and they looked at BASDAI scores and whether it could distinguish between the two. Because we think of BASDAI as an axial score, and it was the same in both groups. And the response to therapy was the same in both groups, even including question 2, which asks you about back pain. So it's a challenge to say, I mean, one, we don't know who has axial disease. And then how do we decide if the axial part is better or not? It's a tricky one. And it's going to be, and it is a relevant question as we move into the era of IL-23 inhibitors, which don't seem to work for the axial disease, at least in AxSpA.
In AxSpA.
Exactly. And so they looked at that in the guselkumab trials, and it worked, but it worked by virtue of improvement in composite outcomes that may just reflect general improvement. We just don't know.
And with the JAK inhibitors coming, that raises the stakes also. Given
exactly. Totally.
Rob, what are you thinking? What are your thoughts on that? Is axial involvement in PSA the same as ankylosing spondylitis or axial SpA, or is it different?
Yeah, I think it's a hard question to answer as well. Going back to that Maximize study, though, one interesting they did find was a reduction in MRI lesions, which take it for as you will. I think especially guselkumab coming up, interesting to see what the JAK inhibitor data will show too. But it's a hard answer at this point.
Let me put in my 2 cents on this, in that I think it's a good thing it's being addressed. I don't think it's an important question, really, because I'm just looking for a reason to take over management of a psoriatic patient. If it's for their axial symptoms, I'm in. If it's for their peripheral arthritis, whether it's poly or oligoarticular, I'm the guy. It's like I get bothered when I get sent to skin only people and like, why are you here when you should be down the road at Alan Mentor's office, their dermatologist. So Artie alluded to the JAKs are coming on, and they're kind of confusing, or expanding our pretty expanded market in PSA therapy. It's going to get more crowded when we start using TYK inhibition. TYK2 inhibitors. Eric, what do you think?
Maybe. So one of the late breaking abstracts this time is, let me try to see if I can do it right. Deucravacitinib.
Artie, how do you do it?
I think it's a very clever name. I think it's, do you crave acitinib?
Oh, there you go. Do you crave acitinib? So, and that's the first TYK2 inhibitor we've seen. It's a phase 2 trial in psoriatic arthritis. It worked, but it didn't look like it was much different than anything else. And it's sort of billed as, well, IL-23 signals through the through TYK molecules, and so that's kind of the pathway. The skin response wasn't that fabulous. It certainly didn't look like the kind of skin response we see with some IL-23 inhibitors. The joint response was good, but it wasn't better than we've had. So I don't know that that's going to shake things up. We'll see.
It's coming tomorrow. Rob, we'll go to you, and then maybe go to Eric for the finale. Stuff that's coming up. I know you have your schedule planned. What you're going to go see tomorrow, and what you're going to go see the rest of the meeting. Well, give us the somebody who said, hey, I want to see what's best in PSA. What should they see in the next couple of days?
Yeah, got it. I think an overarching theme for all diseases in this meeting, just like the last meeting, is machine learning, and you have your gut microbiome. Just like in RA, same goes with PSA. There's going to be a lot of, there's an interesting abstract in gut dysbiosis with radiographic and enthesis involvement, again, tying in that enthesitis theme. A lot of data, even recent or even the past 2 days on machine learning, and there continues to be more machine learning. There is going to be a phase 2b study on tildrakizumab, IL-23 inhibitor. And I believe there's also a late-breaking abstract on TOFA with psoriatic arthritis. And just to tie up with enthesitis again, and having a better way of evaluating enthesitis besides just poking at the Achilles and saying, does it hurt? Yes or no, is there's a
come on.
Yeah, right. But I can't poke the other 200 enthesis points though. But there's going to be an ultrasound study on enthesitis coming up in the next few days, which would be interesting. Ultrasound scoring study.
Eric, what about you? What somebody interested in PSA who hasn't gone through the booklet yet? What the booklet? Listen to me. In 1980. Who hasn't gone through the program listing online? What should they go see?
I would, to quote you, I do crave acitinib, because I do think that's interesting, because it's a new molecule, and it's a new, it is a new pathway, and it opens up something new. It's an interesting molecule because everything we've seen with JAK inhibitors, there's all these sort of heterodimers, and there's sort of the inhibition may cross pathways, and this seems to be fairly specific. Whether that results in anything clinical, we'll see. But I think that's going to be an interesting abstract. Besides that, I'm not sure what else is like earth-shattering. Just a lot of interesting stuff that sort of fills in the holes on sort of extension studies with some of the drugs we've had, fills in some long-term safety data and some of the drugs we've had, sort of some additional sub-analysis of the trials we had to sort of understand in different populations. As I started with, I don't think there's a lot that's earth-shatteringly new in terms of new therapies, but there's just a lot that sort of fills in the blanks with the therapies that we've had so far.
Let me ask both of you, or either of you, research at this meeting about clearing up the issue of what drug is better to use after you failed a TNF inhibitor or more than one TNF inhibitor? Is that an important issue about your next choice of therapy?
It is. I haven't seen much that really helps me there at this meeting, Jack. And maybe you picked something up I missed, but I haven't seen much. I mean, there's, we desperately sort of need head-to-head studies, and we don't have those. We've got 2 head-to-head studies that are TNF versus IL-17. As we move into the JAK space, we're going to need to sort of get some direct studies that say, should you use that's the thing in psoriatic arthritis. We've got all these pathways. We can use an IL-17 inhibitor. We've got IL-23 inhibitors, one approved, more coming. We've got JAK inhibitors that are coming very, very soon. But then we don't know which of those to use, and we're going to need some good comparative data. And I think just taking 2 trials and sort of holding them up against each other doesn't give you the answer you need.
In dermatology, they've got a lot of head-to-head trials, and it seems like it's changed the treatment landscape. Do you think the same will happen in rheumatology?
I hope so, but I don't know. I mean, that's just, for some reason, they've sort of gone down that path, and that's just been sort of the way they've looked at their drugs. I just haven't seen much of that yet. We've got a couple. I mean, what we're going to need is, truly we're going to need is a head-to-head that includes a JAK and a biologic. That's really
Right.
the next place we need to go, and I don't see anything coming in the near future.
All right, gentlemen, I want to say goodbye. Eric and Robert, thanks for joining the panel discussion on psoriatic arthritis.
All right.
You guys are
Thank
going to sign off. We're going to bring in our next two experts, Dr. John Revelle. John, you're on mute. You want to unmute yourself, and Olga Petrina. Okay. So here we are. We're going to do our mid-meeting recap and talk about spondyloarthritis. We're joined by John Revelle from Houston and Olga Petrina from New York. Welcome, folks.
Hi,
Well,
thank you for having us tonight.
Yeah.
Yes, it's great to be here. And I've been over the whole program, and I share Eric's issues. I think there isn't a huge amount that's new to me that was being presented at this meeting. There's a lot of articles on treatment, and I think we're going to talk a bit about that. There's a couple of pulling back. There's some very interesting things being presented on the microbiome, but really pulling back. I think the most striking theme that's coming out with this meeting, whether we're talking about treatment, whether we're talking about disease manifestations, or even genetic profiling, is the role of gender and the gender disparities that we're going to see in it. And I think that's some of the stuff that I'd like to, I don't know if Leanne focused on that last night, but that is what really struck me the most in going over all these abstracts. Again, pulling way back and looking at the overall picture here. Probably, although there's not a lot new in that regard, nonetheless, one of the most compelling things that comes from this meeting.
Interesting. And I think it really helps, I think, better characterize patients, and the more we can characterize them, maybe the better we can treat them. Olga, maybe you should start by telling us something that you've seen so far in the first 2 days that really stood out for you.
Yeah, absolutely. And actually the matter of gender differences, that's something that stood out to me. And that's the abstracts that caught my attention, interestingly enough. So there are two abstracts that I really wanted to discuss, and they all pertain to gender differences. And the first one I will mention will seem like have nothing to do with it, but I will drag you into the woods of gender differences along the way. So the abstract 1303, which speaks initially about the prevalence of undiagnosed axial spondyloarthritis in patients with anterior uveitis and chronic back pain, starts out with the fact that a lot of patients have been referred to us from the ophthalmology clinic actually have symptoms of inflammatory back pain for a very long period of time. And interestingly enough, from most of the referrals who had recurrent arterial uveitis, 87% of the patients had inflammatory back pain way before they were referred to rheumatology. From those patients, about 53% or more than 53% of the patients meet the criteria for inflammatory lower back pain, and close to 30% of them had radiographic findings that could be consistent with axial spondyloarthritis. So as a result, about 23% of the patients were eventually diagnosed with axSpA as they met the clinical criteria. And about 40% in addition to that were requiring a follow-up with the suspicion of possible axSpA. And when we speak about this undiagnosed pool of patients, what stands out the most to me is the gender issue. So what happens is all the patients, female and male, have similar distribution of HLA-B27 positivity, duration of pain, severity of the disease, and you name it all. But when it comes to the actual diagnosis in these studies, 33% of the male patients were given a diagnosis of axSpA, and only 13% of the female patients were given the same diagnosis. So I'm wondering what's contributing to that. Is it the difference in the symptoms? Is it the difference in how patients relay their symptoms to their doctor? Or is there something phenotypically different about those patients?
Well, disease expression in women is with spondylitis has always been problematic and quizzical to me. John, what's your take on that?
Well, there's actually a lot of data being presented at these meetings, actually some from our group, but some from a number of other groups. And that is the strikingly higher prevalence of peripheral manifestations in women with non-radiographic and radiographic axial spinal arthritis, including enthesitis, including peripheral arthritis. What's also striking, looking at some of the clinical trials, now there's only one that didn't show any difference between genders, but like there was one, for example, Maria McGray presented from Metropolitan Hospital in Cleveland with ixekizumab, as well as a number of others, that have shown that women respond less well to biologic therapy than do men. There's an abstract being presented, I believe, on Monday. This is the same group. This is Lee and Matt Brown. They're looking at a different cohort. They're looking at the Swiss cohort, looking at 850 people from that. And what they're trying to do is to use that genetic risk profiling score that they presented as a plenary session at ACR 2 years ago. This time they applied it to a different cohort, the Swiss cohort. And lo and behold, if you look at women versus men with radiographic axial spinal or ankylosing spondylitis, there were no differences in the genetic score. However, when they went to the non-radiographics, the men look with non-radiographic axial SPA look just like the men with radiographic axial SPA using this polygenic risk score. The women, however, look like the general population. So striking differences there, which I think is real problematic as we're trying to make a diagnosis, and it all the more underscores the gender disparity in this disease.
So we're about midway through the ACR meeting. John, you just touched on something that's coming up. That's not been presented as of yet. Olga, I know you have your schedule all planned out. What are you looking forward to tomorrow? And what are you looking forward to for the rest of the meeting in axial spondyloarthritis?
So I'm looking more, I'm expecting more data on, again, gender differences or baseline characteristics of the patients that are different that can actually help us predict how patients would respond to treatment based on not only gender, could be other characteristics. So that's something that's interesting to me. And like speaking of, again, differences between the patients, like this morning, the abstract was presented, the pool data for ixekizumab studies. Again, talking about the gender difference at baseline, patients who were female more likely to have higher BASDI scores just based on the higher nocturnal pain, peripheral joint pain, and overall fatigue, while male patients tend to score higher on CRP and a higher level of HLA-B27 positivity is observed there. So I think that where we start out is important, because if patients have different pattern of the disease or the picture of the disease, they may respond to treatments different. So I would be curious to see more abstract on the treatment outcomes pertaining to different patient characteristics.
John, what else you mentioned?
And well as the data here do show that women tend to respond less well, and that's clearly being seen in the current clinical trials.
Correct.
John,
what are you looking forward to as far as reports or studies that may come out on Sunday or Monday?
You know, there wasn't really a lot on Sunday, but Monday is chock full of in the spinal arthritis, especially in the poster session, with a lot of very interesting abstracts looking at different disease subsets like inflammatory bowel disease. Some interesting papers looking at the microbiome. One shows that the differences in the microbiome correspond to disease activity. Another one looking at calprotectin levels and showed that fecal calprotectin as a biomarker corresponds even in patients with AS with villus damage and blunting. So these are things that I think to me are very interesting as far as pathogenesis is concerned.
How about the meeting overall? How's it affected you? John, you're notorious for, being all over the meeting and meeting people and learning in your own style. How has this virtual thing affected you?
Well, it for better or for worse. It's a lot. Sometimes it's hard to connect to sessions. Sometimes the slides don't come regularly. But what I really like about this is the ability to go back and review all the sessions. And so I'm going to predict that at the end of this meeting, I'm going to learn a lot more because I actually tend to get distracted by the networking. This way I'm having to focus on the science, and that's actually a pleasure.
Olga, what about you?
Well, what I like is the flexibility of it. And I must say, I like it a lot lately. So I can be anywhere and still attend the live session if I wanted to. And similarly, I can just postpone some abstracts and posters for later on, like knowing that they're pre-recorded. What I hate about this meeting is this lack of human communication. I really enjoyed meeting my colleagues and having a little chat or a cup of coffee and talk about things live. I think that's a big minus for the virtual meeting.
All right, folks, we'll wrap it up, and thank you for joining our group discussion. This was a lot of fun. We want to thank our audience for watching. Tune into RheumNow for more videos, more stuff from ACR 2020. Thanks.
Thank you.
Thank you.
Thank everybody.
All right, folks, I'm going to stop the recording. Olga, thanks for joining. Artie, we got through another thing.
Oh,
Thank you so much.